So our first speaker is Dr. Rochelle WINIKOFF. Rochelle is a hematologist, and she's the director of the Women and Bleeding Disorders at St. Justin Hospital in Montreal. She's a leader in the field of women and bleeding disorders. She's also the chair of the Women and Bleeding Disorders Subcommittee of the HEDC and the co-chair of the coderouge 2018. Her presentation is entitled Overview of What We Know and What We Don't Know in Women and Bleeding Disorders.
So thank you very much for that introduction. And what I'm going to try to do today, well, first I'll tell you that I don't have any disclosures relevant to this talk, except that I'm really happy to be here. It's a little emotional too. The goals of my talk today are to give a perspective on women and bleeding disorders, to give a general outline of what's in store for you today. So this is a little unusual as an introductory talk where I'm going to touch on different aspects throughout the day and even on some of the breakout sessions that many of you won't be able to all assist at the same time. And I'm going to try to point out some unresolved issues. And I want you to seed those ideas in your heads before you hear the rest of the talks, because the talks will go through many of those issues throughout the day and the afternoon. Looking at trends first, there's no question that the trends are increasing for the number of patients with bleeding disorders. This graph from the World Federation of Hemophilia from 2016, from the annual global survey of 2016, shows that there's an increase in the bars in purple in hemophilia, in von Willebrand, in the blue bars, and in the red bars of the rare bleeding disorders. There's definitely a female preponderance in von Willebrand, in platelet disorders, and even in many of the rare bleeding disorders. What does the picture look like in Canada? At the current time, and the latest data I have is from the Canadian Hemophilia Registry, there are 2,500 women diagnosed with von Willebrand disease. There are 360 carriers of hemophilia, or women that carry the gene for hemophilia, and many with rare bleeding disorders. Just in terms of von Willebrand, we can expect, using a symptomatic prevalence assumption of 1 in 1,000, we can expect 21,000 females with von Willebrands in Canada. There's a social stigma that's associated with talking about periods and postpartum hemorrhage. And I think if we go back 20 years ago, we'd all agree that no one talked about any of this. But that stigma is slowly lifting. Women that have menorrhagia and that suffer from excessive bleeding have diminished quality of life. And this is an excerpt from a study, a Canadian colleague in 2006, looking at quality of life, where quality of life is represented by a perfect quality of life is represented by a score of 1. We can see that adult females with von Willebrand disease have a score of 0.7, so already diminished quality of life. Compared to a male with von Willebrand, they have a higher score, so a better quality of life at 0.77. But what's really striking is if you look at females under 45 years old that have a bleeding disorder but also have menorrhagia, their quality of life is at 0.64. And that's very close to what the quality of life is reported by hemophiliacs that are HIV positive. So this slide is very striking to me for what it says about the impaired quality of life in many of the women that we're talking about today. As a community, we've responded with outreach programs like Code Rouge and equivalent programs in the United States called Victory for Women as part of the American Women and Girls Foundation. There's a new mindedness that's on the horizon, the next generation. So we've lifted a taboo and now we're headed to a different philosophy about women. And what we know is at the royal wedding, there were different charities that were designated by the royal couple. And one of them was to empower women in India, in a certain region, by giving them access to feminine hygiene products and employment opportunities. So I think that we're in a trend that's changing in terms of opportunity to help women and to advocate for women with bleeding disorders. Publication trends are not far behind. The slide to the left shows that there's an increase in publications in women and bleeding disorders. And to the right, what I've showed you is this, it's very hard to see the graphic, but a very steep increase in the number of reports regarding postpartum hemorrhage. So the literature has completely exploded regarding postpartum hemorrhage since 2011. Women that have bleeding disorders suffer from a lifetime of bleeding. And many of you have seen this slide that I use often, but it's not for nothing. So of course you can bleed at any time of your life, but the bleeding is most pronounced at the time of menarche, at the peripartum, and we now know in the perimenopause. Looking ahead, though, we know we're going to be faced with these issues more often because contemporary women will have 450 lifetime menstrual cycles versus 160 in ancestral women. And that's because women are having their periods earlier, they're having fewer children, there's fewer periods of extended breastfeeding and late menopause. And we also know that women are going to have higher risk pregnancies as time goes because of older age and multiple gestational pregnancies. Looking at screening. Now this is a bit of a complicated slide. I'm just going to take you through the main points. This slide looks at the number of cases of von Willebrand's disease, men and women combined. And what you can see is in Canada, 4,437 cases are reported. And we saw on the other slide that a bulk of those, 2,800, are actually women. Most of whom, or half of whom, are between 19 and 44 years old, and 15% around adolescent age. If you compare it to the statistics that were in 2012, you can see that the number of patients diagnosed with hemophilia was identical to the patients diagnosed with von Willebrand disease. And that shouldn't be, because we would expect in the Canadian population to have 36,000 cases of von Willebrand in Canada, again using the symptomatic prevalence of 1 in 1,000. And for the first time in the report in 2016, we see that for once, the diagnosis of von Willebrand surpasses the number of cases of hemophilia. And I think that we're starting to go in the right direction with screening. Looking at screening trends amongst physicians. Now, I'll try to take the humor out of this, but one of the quotes said that hematologists are a little bit better than gynecologists in screening. Now, I didn't put that because I didn't want to offend anybody. These studies are all US-based studies. They all look at trends in the way physicians think about when to think about von Willebrand. And in 2002, the first one was published, surveyed about 400 physicians that are all gynecologists, and only 16% of them screened or thought about screening for von Willebrand disease. And only 4% thought of screening the women that were in the reproductive age, as opposed to adolescents at the time of menarche. So that's strikingly low. In a later survey, not the same authors, but in a bigger group of physicians, also obstetrics, 77% thought to screen for von Willebrand disease. So I think that things have changed in the last 10 years. 77 would screen, and 36 would screen at the time of reproductive age. And because of worries about pregnancy and dealing with potential bleeding at that time period. And the last study looks as a numerator and a denominator in terms of the number of patients and not physicians here. But still the numbers are low. 8% are being screened and 16% if they're bleeding heavily. So when looking at it that way, we still think there's a big job to be done in terms of education and screening for women. The screening tools, we're going to hear a lot about this today. I just want to point out to you that there are screening tools for menorrhagia and there are screening tools for bleeding disorders. People mix those up sometimes. So what I've shown here is that for menorrhagia, there are standardized questionnaires that the Americans have published many years ago. There's the pictorial blood assessment chart that's a semi-quantitative score that helps physicians screen for the presence of menorrhagia. And there's a bleeding score that we're going to hear Dr. James talk about in detail soon. But these are bleeding assessment tools, some of which are self-administered, that have actually, that's a typo, that should be a high negative predictive value in von Willebrand disease. So it's as good as a screening test, and it's been validated in other populations as well. But what we don't know about screening tools at all is what are we using across these countries? When we look at these statistics and these reports, we don't know what physicians are using. Are they using a questionnaire? Are they using a bleeding assessment tool? We don't know if the screening tools are different across different age groups, medical practices, and even countries. And here's a photo of the Diva cup, which is a silicone cup that collects menstrual loss. That's not very popular in Quebec, but I understand it's very popular in Ontario. And how that changes the need for menorrhagia screening tools, and how those measures of blood loss can be integrated into the bleeding assessment tools is a question I asked the audience. And then how the PBAC and the bleeding assessment score, when applied to patients with menorrhagia, when you're looking at the patient who's bleeding, the question is, do they perform equally? How do they compare head to head? And is there any value in combining them? Some of the questions I ask. Looking now at lab screening, we're going to hear a little bit about this. I'll just say that it's pretty much a nightmare. That would be one slide. It's fraught with complications, blood draw, pre-analytical variables. There's certainly a lack of agreement and even availability of the PFA 100 to screen for von Willebrand and platelet disorders. And there's definitely inconsistencies in the measures of von Willebrand factor and platelet function testing. That's what it looks like. What we don't know about laboratory screening is what's the right cutoff. I mean, all of you in this audience know very well that we struggle with this all the time. Is the level of 50% right? How do you distinguish individuals that have low levels of von Willebrand factor because they're blood group O or the mild forms of von Willebrand? And what we also don't know is if we test for platelet function up front, does that change all of these statistics? We usually use stepwise. Most centers, I think you would agree, you look for von Willebrand first because it's the most common, and if you find it, you stop. But if you were to test for platelet function up front, and there's some studies that suggest that platelet disorders may even be more common than von Willebrand in some populations. And what we also don't know is how genetic testing will change diagnostic trends. There's a significant number that are reclassified once you have genetic testing, and in particular, there's some type 1s that are now called type 2M in some of the registries in Canada. When you do all the screening, and now you've thought about screening, and you've thought about what test you want to do to look for it, what are you going to find? The Hallmark study in 1998 by Rezan Kadir showed that the most likely diagnosis that you're going to find is von Willebrand disease. To the right, I show a summary from expert from Dr. James' article in clinics and gynecology clinics in North America in 2009. And what I've highlighted in red is the different prevalence of von Willebrand you're going to find when you screen different populations. This is very population dependent. You're going to have more von Willebrand diagnoses in an inpatient population, presumably because they're sicker and they're bleeding more. And in a tertiary care center where you have an element of referral bias, the patients get referred from a family practice to the hospital and then to see hematologists, you're increasing your chances of making a diagnosis. And so what the literature looks like is this. You have a range of 5 to 36% in von Willebrand diagnoses. What does it look like in terms of a summary? Now, this is a very old slide, and I show it often because I feel that it still represents our current understanding of bleeding. This is a summary of different menorrhagic and postpartum bleeding in rare coagulation defects, von Willebrand, and carriers of hemophilia. And I won't go over the whole slide, but suffice it to say that all of these groups have an increase in postpartum hemorrhage and reported in about 50%. It seems that the antepartum bleeding, then the column closest to the right, is fairly uncommon in von Willebrand disease compared to the rare bleeding disorders. And all of the subgroups suffer from menorrhagia and perhaps a slight increase in perimenopause bleeding in von Willebrand group. How do we treat? We're going to hear more about this in the afternoon breakout session. So I'll just summarize. This is a slide from Chi et al. In Contraception 2011, just looking at an adult population and what the choices for treatment were. And what you'll see is oral contraceptives, antifibrinolytics, the Mirena device, and desmopressin that's intranasal. We know that the oral contraceptive pill is effective as first-line therapy, and that's the recommendation to start if there's no contraindication. We know Mirena is very effective. There's a high rate of amenorrhea, but there's an increased expulsion rate that we now know that's been published. Tranexamic acid is an effective non-hormonal alternative, and many centers will, in von Willebrand patients, use intranasal DDAVP. In some provinces, and especially I would say that in Canada, we underutilize DDAVP intranasal, and I think if we asked our American colleagues in the audience, they're going to tell us that they prescribe it perhaps more than we do. But what we don't know about how to treat menorrhagia is we don't know if replacing von Willebrand factor could be more efficient on quality of life outcomes and even treatment outcomes in menorrhagia. Is it more effective than DDAVP? Is it more effective than non-specific hemostatic therapies? There's an American study that I understand that's going to be taking off addressing this. We don't know the response rates with what I call the mini Mirena devices that are used in adolescents called JADIS and Alicina. We don't know how they're going to pan out compared to Mirena in the younger group and compared to cyclocapron in the pill. We have no idea what the number of unwanted pregnancies are in adolescents that are being treated for menorrhagia. And we definitely don't have a good incidence data on thrombosis rates, especially with combined modalities. Turning to bleeding, that we're going to hear a little bit more about in bleeding in pregnancy in the next session, I would just suffice to say that this is a chart showing that factor VIII increases in pregnancy in von Willebrand patients. Pregnancy in general is really good for women with bleeding disorders. You might not get hemostatically better, but by and large, pregnancy improves hemostatic parameters, and especially for von Willebrand and carriers of hemophilia. And women who don't correct end up having a hemostatic prevention at the time of delivery. But we don't really know is what the appropriate hemostatic level is for epidural or for bleeding or for delivery. And here's an excerpt from a guideline from in 2011, and it's telling us that 50% is okay. I'm not sure that we actually know that. Physiologically, women go up to 200-300 at the end of pregnancy, and that's to protect them from bleeding. And if you're only going up to 50, the question is that enough? We also don't know what the miscarriage rates. The only two studies that I found that quote these that are prospective but don't use a validated screening bleeding tool suggest that it ranges from 5 to 15, which is comparable to a normal population. We have no idea if we should be giving, for example, in a von Willebrand patient, if we should be giving her factor in the antepartum period to prevent bleeding. We don't have any experience with it. Which hemostatic parameters best predict hemorrhage? Is it, in a von Willebrand case, is it the function? Is it factor VIII? Should we be looking at TEG or RODEM to decide? And we don't know the best strategies to decrease postpartum hemorrhage. Which product, how long, how much? And the relative contribution to bleeding, the postpartum hemorrhage that bleeding disorders add. So if you're looking at a patient who's had atony, you can see that that's a major risk factor for bleeding and postpartum hemorrhage. And the question is how much added contribution does the fact of having a bleeding disorder add to that risk? And I don't think we have those numbers, and I'd ask you to think about that throughout the day. And we certainly don't know the contribution of iron deficiency anemia to the risk of postpartum hemorrhage. There's going to be a more detailed video presentation on the use of TEG and RODEM in postpartum hemorrhage. But I want to point out two modalities that we know. Tranexamic acid is good when it's used early in postpartum hemorrhage. And we know that low fibrinogen levels predict ongoing bleeding. And you should probably keep the fibrinogen fairly high and higher than in other populations. But we have no idea how to manage postpartum hemorrhage in women in bleeding disorders. In other words, do we use specific factor in von Willebrand, or do we mix it up with the fibrinogen and the cyclocapron, and in which order? How do we measure postpartum blood loss? I think there's no consensus on the best method. Do we know what the role of cyclocapron is in bleeding disorders? We don't know the best modality to substitute fibrinogen when we need to, and we certainly don't know the role of TEG and RODEM in the management of PPH. Looking to services for women with bleeding disorders, we're going to hear some data about the treatment centers in the afternoon by David Page, by a survey that was sent out. We know from the American data, and this is a slide from the US, showing that the number of women with bleeding disorders registering in hemophilia treatment centers across the country in the US, but also in Canada, are increasing. What we know about hemophilia treatment centers, we know that it has many benefits for male hemophiliacs. It improves healthcare utilization and improves outcomes. We know that the benefit of multidisciplinary clinics has been shown for other diseases, including migraines and other complex diseases. And we know that it's viewed positively by many women who attend these clinics. But we actually don't have any data to show whether, like in hemophilia, that it improves care or outcomes. Are the needs the same in adolescents and older female populations? We have no idea if there's access to care differences by gender, age, region, country. We have no idea. And we certainly don't know what model works best. And I hope that those of you attending the workshop in the afternoon will get your opinion made on what works best. And looking at outcome measures, so in menorrhagia, once we have a diagnosis and once we've treated menorrhagia and postpartum hemorrhage to the best of our ability, how do we know if we're making a difference? So typically in menorrhagia, we look at self-reports, we look at PBAC scores, we can look at hemoglobin values or iron. In PPH, we can look at blood loss, we can look at hemoglobin or iron levels, and the blood loss is usually by visual estimation or collecting blood on a drape. And of course, we can rely on self-reports. But what I would say is that the tendency in the future is looking at patient-reported outcome measures more and more. And I don't know that the numbers actually matter as much as the patient's perceptions. And I'm going to read you a quote from one of the facilities that care for patients. This comes from a territory in the United States. But I love the quote, and I'm going to read it to you to end. It moves the focus away. The modernization of care moves the focus away from who provides the care and places it firmly on the quality of services experienced by and the outcomes achieved for individuals and their families. It provides a means of gaining an insight into the way patients perceive their health and the impact that treatments have on their quality of life. And we're going to be more and more, not only today, but moving forward, looking at outcomes that include willingness to pay, quality of life across ages, psychological impact scores, and comorbidity scores. And I think that's the trend in the future, and I think we'll be looking a lot less at PBAC scores and bleeding measurements at the time of delivery. And so I'm going to end with a photo that I think summarizes, where we're going with women and bleeding in general. Here what you see is the woman at the center of a multidisciplinary team, making sure that she delivers a safe baby, making sure that the mother is not hemorrhaging. And they're all communicating, or trying to communicate with each other. But I think that this is the picture that I see coming in the future, where the mother is not still at the center, but she's also in the driving seat. Thank you very much.
We have time for some questions.
Now, all of these topics will be addressed throughout the day. It was meant to be somewhat of an overview, but also to pique your interest in things that we really don't know, and hopefully, like we said at the beginning introduction, stimulate ideas for research and projects, certainly in the areas that we know nothing about yet. So I don't know if there's any questions that I can answer right away before we go into the specific talks.
It's not working. Now it's working. I just wanted to bring up the epidemiology of these bleeding disorders because, Mina, you made a point that von Willebrand's disease is becoming increasingly recognized and the numbers are going up. I do want to point out that the carriers of hemophilia, some of the slides that you showed sort of suggest that it's not common. And it may not be appreciated. But in fact, being a carrier for hemophilia may be almost as common as having von Willebrand's disease, but 80 to 90% of carriers are just never recognized, right? So it's actually a very common thing to be a carrier for hemophilia.
Correct, and we actually don't know the numbers that we're expecting in the future, and that's because the longevity in hemophilia, as you know, has changed. More and more women will be carrying the gene of hemophilia and passing it on, and that probably explains the increase in incidence in hemophilia in the general slide. But in the women's group, you can see that the numbers are quite significant, and they do trail behind von Willebrand to a significant degree, but the numbers are steadily going up as well, and people are becoming more and more aware that carriers can have bleeding and so forth.